Emergency medicine is more than just ordered chaos.
From the resus room to the bedside, we are witness to it all.
And we're here to help you prepare for it.
Bringing you the brightest minds in emergency medicine from around the world for trusted, tried, and true free open access medical education.
I'm Dr. Anton Hellman.
And I'm Dr. Katie Lynn.
Katie, let's welcome the listeners from our amazing EM community to the Emergency Medicine Cases podcast, shall we?
Yeah, or let's simply call it EM Cases.
Okay, EM Cases.
EM Cases is brought to you by SHREMI, the Schwartz-Reisman Emergency Medicine Institute. That's a nonprofit organization dedicated to improving EM care through high-quality research and education. The opinions expressed on this podcast are intended for information and education purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician.
First, just a quick word from our sponsor, Metricade, the experts in complex physician scheduling since 2012. I've been using Metricade's incredible scheduling system for more than a decade, and it's been a game changer for me and my colleagues. Shift work comes with its challenges, but Metricade helps minimize the drawbacks by ensuring fair distribution of shifts while integrating circadian rhythm-friendly recovery time into its methodology, preserving your precious sleep so that you can perform at your best. Go to metricade.com/emcases to see how Metricade can make your scheduling fair, improve your sleep, and your performance. That's metricade.com/emcases.
This is another special edition of EM Cases. At this year's Emergency Medicine Update Conference, or EMU, one of Canada's biggest and best in-person conferences run by North York General Hospital, I've been on the organizing committee for many years, and I've spoken at this conference many times. I was honored to be invited to interview a select few speakers on the topics that they covered in their talks at the conference. And to kick off the series, which you'll find sprinkled into future EM Cases Quick Hits episodes, this interview, which was initially supposed to be 20 minutes long, was so enlightening and fun for me that we ended up chatting for almost an hour, and so I decided to present it here as a main episode podcast. Sit tight.
Our guest today is Dr. Amit Shah, an emergency physician and associate professor in the Division of Emergency Medicine at Western University in London, Ontario, Canada, with a career spanning academic, community, rural, and regional leadership roles across Ontario. He works at St. Thomas Elgin General Hospital. He's a peer-to-peer consultant and currently serves as emergency department lead for Ontario Health in the Southwest region of Ontario, working to improve emergency care systems at scale. Dr. Shah is known for his practical, bedside, focused teaching and deep experience in clinical decision-making across diverse settings, which gives him a very unique lens on what we're going to talk about today, which is how to make decisions about imaging in the emergency department.
Thanks, Anton. Great to be here.
And Amit, if it's okay with you, what I'd like to do is run through a few cases. And with those cases, we can then highlight some of the key points that you want to talk about.
Yeah, perfect. Yeah.
Great. All right. First case. A 42-year-old female has a history of chronic recurrent abdominal pain and vomiting. And this time she comes in with abdominal pain and vomiting that started yesterday. She's had multiple scopes, hospital admissions, and specialist consultation, which are all non-diagnostic. She's had 15 CT scans over the last 10 years, with 10 of these being abdominal CTs. Her labs, vitals, and exam in the emergency department today with you are unremarkable. She's insisting, however, that she needs imaging and that something is definitely wrong with her. She starts crying when you told her you may not order further testing. Now, we have probably all had these patients, and I want to really get into the radiation risk concerns with CTs because it seems to me that over the last decade or so, especially the last 5 years, we're ordering more and more and more and more CTs in emergency departments across North America. I personally, since I've been practicing for 25 years, the longer you practice, probably the less CTs you're going to order. I'm in the lowest quartile of CT orders in my group where I work. And I even feel like I'm ordering a gazillion CTs. So let's get into this. So does this patient need a CT? And what are the kind of things that you're going to think about in order to make that decision?
Yeah, this is, you mentioned you're in the lowest quartile of orderers. Some days I feel like I've ordered a CT on every patient I've seen, despite years of experience. So this comes up for all of us all the time. From the literature perspective, it came to a head last year when a paper was published in JAMA Internal Medicine last year where they described CT usage in the States. And some of the highlights are 93 million CTs ordered in the States in 2023. The anticipated cancer effect of CT ordering is 103,000 cancers caused by those 93 million CTs directly associated with those in the future. And in their paper, they described that they felt that 5% of new cancers in the future would be associated with CT ordering. So those numbers are staggering. So that's the system effect of ordering CT. Now, on the other side, we constantly work a balancing act in emergency medicine of knowing that CT is an essential, tremendously useful test. There's a reason why CT ordering rates have risen exponentially. It's because we do a way better job of diagnosing things early now as compared to 25 or 30 years ago. So it certainly works, but what are the risks with CT? There's a few simple things for us to think about. If you're framing the risk to patients and to yourself, which I think is the most important pearl, one PA chest X-ray is 0.2 millisieverts of radiation. And if you do a PA in lateral, it's 0.1 millisieverts. If you want to translate that into plain English, you can tell patients that if I'm ordering a CT head for you, that's 100 chest X-rays of radiation. If I'm ordering a CT abdo-pelvis, is 500 chest X-rays of radiation. You can frame each of these tests in terms of number of chest X-rays of radiation for the patient, which is a number that people understand. And the second thing people want to know, and you yourself want to know, what is that effect of radiation down the road? And of course, the concern that we have is the risk of cancer. And you can quantify that risk for people. If you order a CT abdo-pelvis in a 40-year-old female with abdominal pain like this, the risk of cancer down the road is about 1 in 400 or 1 in 500 as induced by this CT scan. So giving that patient an idea of what their cumulative cancer risk is very helpful. You can actually go to a website that's tremendously useful to use and is free and set up by radiologists. It's called xrayrisk.com. You simply punch in the age, what study you're doing, and how many studies you're doing, and it'll give you exactly a number of 1 in 800 cancer risk or 1 in 400 cancer risk. I don't go to that website for all the patients I see, but for example, in this patient who'd had 10 abdominal CTs in the last 10 years, I was able to quantify for her that your risk of cancer now is over 1 in 100 just from the scans that you've done. And every scan that we do is cumulative. So this concept, when you're discussing with patients the merits of doing a test or not, I think puts it into plain English for people and for yourself. What is the effect of what I'm going to be doing?
Absolutely. Another common presentation we see is renal colic. Every renal colic patient, I just ask them how many CTs they've had. Because, sometimes we're just going through the patient and say, oh, they're renal colic. To prove it to myself and to the patient, I'm going to get a CT renal colic. And maybe we don't take the time to actually look through or ask the patient how many CTs they've had. And I've just been amazed at how many patients have had 10 or more CTs for renal colic. And that's a whole other discussion of whether all patients with renal colic need imaging at all. You could very well argue that many of them don't need any imaging.
Absolutely.
Yeah.
So when you look, and now with our electronic medical records, we can actually add these up very easily. And when you turn the tab to look back through their history at their radiology, counting those CTs is amazing. And what I do is I actually tell patients, I go and count their CTs, and then I tell them, you need to know this yourself, because when you come in and see us in Emerge, our primary job is to try and figure out what's wrong with you right then. But you need to know yourself that you've now had 12 CTs, and the radiation risk exposure for you developing cancer is cumulative. It's not like you get the scan and it goes away a year later. This damage to your DNA is cumulative over time. So we don't need to be overly fearful about it. We need to order a test that's necessary. We need to forge ahead and make decisions. That's our job. but we also should have some way of quantifying the risk for ourselves and our patients. And it's also useful to know that the risk is much higher the younger you are. So all of our efforts to preserve CTs and reduce CTs in younger patients are tremendously important. And as you get older, the risk becomes less because the cancer is going to be induced 10, 20 years down the road potentially. So that age factor is also really important to keep in mind.
Absolutely, yeah. I mean, this is where really shared decision-making comes in, right? And it all depends on your pretest probability. In this patient, if your pretest probability is near 0, you're really going to have a long conversation to really try and advocate for the patient not to have a CT scan done.
Yes, I think when patients have discussions with us, they want us to take leadership and say, there's some cases where you say, yeah, you need the CT and there's some radiation involved, but you absolutely need it. There's other times when you say, you absolutely do not need this and here's why. And in this case, I think the approach would be for most people, tincture of time. So if she comes in with a brief duration of abdominal pain and a history of the same in normal vitals and lab work and a history of that many CT exposures, you could make a very good argument simply for a tincture of time and say, we'll serially examine you as opposed to doing imaging right now, which is an underutilized tool in emergency medicine, right? So we sometimes want the answers right away when it's maybe not the best thing. So
you're reminding me of the days before CT scan, when both of us were working in emergency departments, when there was no CT scan to get access to. And that's exactly what we did with all these patients that weren't super sick that we needed to call the surgeon right away. It was the tincture of time and re-examination. So yeah, I agree that option's been kind of forgotten about almost.
And people are appreciative of that, and in general, are understanding of that in most cases, because they also don't want imaging or longer stay in emerge or other interventions that they don't need. And as long as you can book them some interval follow-up or have an actual outlet for them to have care in a serial fashion, people are appreciative of that. I think letting them go into the wind without actual follow-up at times is a problem for them, right? Because our healthcare system's under stress, and if they have a nebulous follow-up, that can be problematic for people.
Agree. Before we go on to the next case, could you share with us some of your shared decision-making language that you use when you're talking about imaging and radiation? Like, what do you actually say to the patient?
Yeah, I 100% agree with you that the language is important. And I think the very first thing to do is to set that common stage and shared purpose. So I'll tell people, first of all, the truth for all of us is, I want to help you in the best way possible. And this is very frustrating if you have pain and we don't have a specific answer for you. So we're going to try and figure out the best way to sort that out. And then I lay out the options for them. I say, we have the option of doing a CT scan for you, and here's what it potentially could tell us. And if I don't want to do it, if I think that it's not in the patient's best interests, I explain to them in plain English language why. And I tell them, your vitals are normal, your lab work is normal, and here's the risk to you. And it's easy for me to get a CT scan. I emphasize that for them. It is easy. I can get a CT in my regular community emerge that I work in very easily. If I'm in a rural setting and I can't get the CT, I tell them that I want to help them the best way possible. And if I want a CT, I'd have to transfer them and do this. But I don't make it about the effort or the system resources involved, because everyone wants to know you're looking after them, not the system. Really, at the time they're ill, they don't care about the system. You need to emphasize what is going to be the best thing for the patient. And I often frame it as, listen, here's the advice I would give you if you're my sister or my uncle. I frame it in terms of, how would I care for you if you're my relative or my friend? And I try and frame it in a way that they understand that we are trying to give them the best advice, as opposed to limit their access to needed resources, which I think some people come in with a chip on their shoulder that they have already anticipated that people don't want to help them. And some people, they've had experiences or a personality such that they come in with that presupposition. And one of the beauties of emergency medicine is taking people in that mind frame and moving them to a place where they know you're trying to help them, which isn't always successful, unfortunately.
Right. I'm feeling pretty good right now because I respect your incredible career and you as a clinician, and I do pretty much all those things you just talked about. I've used those exact discussions and language as well. So I'm glad that
we're simpatico on this.
We're simpatico, exactly. Yes. I'm glad that we're simpatico on this. Let's move on to case number 2. Case number 2 is a 20-year-old male with abdominal pain that's been progressive since that morning. It started kind of periumbilical. Now it's migrated down to the right lower quadrant. Our listeners already know what the diagnosis is. The vital signs include a heart rate of 108, a temperature of 37.9 degrees Celsius, a blood pressure of 145/85, and normal oxygen saturation. He's tender at McBurney's point. There's no peritoneal signs. He's got a positive row of Sings. And now it's 11 p.m. Now at your hospital, you can't get an ultrasound at this hour, but you can get a CT. And this is, I think, quite common. Actually, the hospital that I work at, we actually have 24/7 CT now, but we can only get ultrasound until 11 p.m. So this is exactly the situation that I work in. The question is, do you order a CT now, or do you wait until the morning for an ultrasound? And really, sort of the sub-question is, what's the risk of deterioration or perforation if we wait for 8 hours for the imaging? And then we'll get on to whether you would give antibiotics or not. But let's break those down one at a time. So would you order a CT now or an ultrasound in the morning, and why?
Yeah, this question comes up for us routinely, right? Do you want to know, do I need to know the answer this second? What happens if the patient perforates overnight? What is the risk of perforation? So there is evidence that can help guide us. So what the evidence shows is that your risk of perforation goes up significantly after 48 hours of symptoms. So their duration of symptoms is a good indicator as to how quickly you want to get your imaging. That's one factor. Now, the other factors, thankfully, are actually quite intuitive and exactly what one would think to raise your level of concern that they need intervention sooner. Obviously, if they have a peritonitic abdomen, you're worried that they may have perfed sooner. So if they have peritonitis, they're coming in and they're getting imaging. If they are clinically full-blown septic, meaning hypotensive, tachycardic, temp greater than 38.5, those are all risk factors that they have something bad going on. And then lab work can actually be helpful. The literature does suggest that you're at higher risk of progressing to perforation if you have a white count over 15 or a CRP over 100. So we often deride the use of lab work. I've said to
Wait,
students.
Hold on. We got to pause there, Amit. You just said that a white count over 15. I mean, we've been teaching our residents and students forever that a white count is almost useless for 95% of what we see in the emergency department. But this is interesting. We got to pause here. So a white count over 15 is one of the indicators that they're at higher risk for a perforation.
Yes, and one of the indicators. So it's associated in studies that if your white count is higher, you are at higher risk of perforation. And that shouldn't actually be that much of a surprise to us, even though we do teach the students and residents the white count is the last resort of the destitute and don't make decisions, based on this. But the reality is we use each of these pieces of information in context of other pieces of information to decide what is my degree of concern. So if this patient's heart rate's 108 and their white count's 10 and their pulse comes down with a bit of fluid and they are looking well otherwise and their abdomen's soft, I'm less concerned. But if their white count is 20 and their CRP, if I measure it, is 130 and their pulse is going up and their temperature climbs to 38.5 in the department, I'm actually significantly more concerned. And I have to make a decision then, am I going to image them that night with a CT, which involves radiation exposure to a 20-year-old? What time is my ultrasound available? 25 years ago, we would send some of these people directly to the OR, which never happens in my institution anymore. The surgeons want imaging, understandably, because we've actually eliminated the appendectomy rate for a benign abdomen or benign appendix now. So you can understand they don't want to expose them to operative risk. And so imaging is important, and knowing these risk factors can help you time your imaging. Certainly, as I said, over 48 hours, every day past 48 hours is a risk factor. The other thing I'll mention is that, once again, intuitively, or as we would expect, extremes of age tend to present atypically for appendicitis, and you should keep that in mind, that those people are at higher risk of perforation because they tend to present atypically. So very young children and the elderly tend to present atypically with appendicitis, and people who are obese are harder to examine and tend to have more difficulty localizing pain and present atypically as well. So those people are at higher risk of perforation just because they're tougher to diagnose and we can miss the diagnosis initially. They may present with mild pain and just vomiting or other symptoms that are atypical.
Great. Those are great pearls at the end. I've never really thought about that, but absolutely. So pediatrics, older patients, obese patients, they're going to either present atypically or be difficult to examine. And I just have to say, I hereby declare that the white blood cell count is not totally useless. Anything else you wanted to add about this second case for appendicitis and the decision to wait for ultrasound or do CT?
The only other thing I'll mention is about antibiotics that we talked about briefly in terms of should you give antibiotics or not. Now, the data is a little bit conflicting on that, actually. On the one hand, as you know, early antibiotics in sepsis or cases of bacteremia are shown to be associated with better outcomes. So we should think about antibiotics. And it is proven that giving a dose of antibiotics before the OR for proven appendicitis will reduce your risk of postoperative complications. So if we make a diagnosis on CT, you should order up that ceftriaxone and Flagyl. The data that's existing does not support giving a dose of antibiotics to people who are still appendicitis on spec and are awaiting imaging to confirm the diagnosis. So unless someone was very septic looking or had some other concern where I was thinking of admitting them anyways, those people who are just coming back for imaging in the morning, the current data support just sending them home without a dose of antibiotics until you make the confirmation. So these are essentially the lower risk patients. You're not sure, but you're suspicious of the diagnosis. If they're well, they can go home and come back in the morning without a dose of antibiotics.
Okay. So in other words, there's no evidence that giving antibiotics on spec before the diagnosis will decrease the rate of perforation.
Correct. That is exactly right.
Got it.
In case you haven't heard yet, tickets for the next virtual EM Cases Summit are currently on sale at emcasessummit.com. Please join us November 21st, 22nd, and 23rd for 3 days of the best EM cases speakers from around the world, state-of-the-art procedural demonstrations, expert panel discussions, rural EM sessions, prize giveaways, and fully accredited CME. It's also a great opportunity to connect with emergency clinicians from around the globe. And if you've been enjoying EM Cases for free over the years, attending the EM Cases Summit is one of the best ways to support our mission and help us continue producing free podcasts, blogs, videos, and all our educational resources. Visit emcasessummit.com for all the details, and please know that space is limited for some of the sessions, so get your tickets soon before they sell out.
Case number 3 is that of a 30-year-old male who was out at a bar drinking, and guess what? He hit his head, which never happens, right?
I think you neglected to mention he was minding his own business too.
Oh, yeah, of course. So he's vomited 3 times, non-bilious, non-bloody emesis, and it's unclear if the vomiting is related to his head injury or his alcohol ingestion. His GCS is 15, so he's looking good. There's no skull fracture that you suspect clinically, and you are the physician at a fly-in nursing station. Okay, so we're talking rural here. The question is, do you fly him out for a CT head or not?
Yeah, so this is a fascinating question and comes up in my clinical work too, because I'm a peer-to-peer physician, and so we support nursing stations around Sioux Lookout. So if you have ever worked in these remote communities, either personally or provided support for them, we are talking about limited resource settings where transport out of the community can be very challenging at times due to weather or transport logistics. So these are high stakes decisions all of a sudden for a case that may be extremely simple in a community emerge like I generally work in. This is not a complicated case, but now you're trying to decide, is it worthwhile to send this person out or not? Am I going to be sitting on someone who has an evolving intracranial hemorrhage in a nursing station if I wait too long for their GCS to deteriorate? Or am I going to be shipping someone for no reason and all of the expense and cost and resource utilization that entails, which takes resources away from other communities? So high stakes decision. So we actually have some new support coming out for this kind of scenario by way of a lab test. So this is actually fascinating. And I think some people may have heard about this, but there are now traumatic brain injury markers that have been studied. So there's been research going on this topic for 20 years. And there have been recently a couple of publications that are supportive of using traumatic brain injury markers. And essentially, you're using 2 markers in North America that are approved by FDA and Health Canada, and they are available actually in Canada in an iStat cartridge. So I think many people are familiar with these iStat devices that are used particularly in rural emerges that don't have an on-site lab. They're used in nursing stations, remote facilities. So you plug in the cartridge, you draw a blood test, and these two markers peak at different times over the initial 24 hours, such that if both markers are negative, you have a 98% sensitivity for bleed, and you have a 99% plus rule-out rate for intracranial hemorrhage.
That's pretty good. I guess the question is, how does that compare to the Canadian CT head rules?
Yeah, brilliant question, and exactly the right question we should be asking. So the problem, and there's always a problem with testing, isn't there? The problem with this testing is that it's similar to D-dimer in that it is highly sensitive, but not particularly specific. So it's actually less specific than the Canadian CT head rule. So we can't rely on it as a first test. That would be the absolute wrong thing to do. What we can use it in is in a setting where ruling out intracranial hemorrhage that cannot be ruled out by the Canadian CT head rule. So specifically the scenario where the person fails the vomiting criteria. Or let's say you have a patient who's 65-year-old plus, but looks well, hits their head, is in a remote community, and you want to decide whether you need to transfer them or not, and they're not on anticoagulants, so they're not a high-risk patient. Those patients who fail the Canadian CT head rule, which you should apply first, and have a diagnosis that can't be made on site and it requires significant resources transport, you can start to think about these tests to use. So I would anticipate, looking at the data that's available right now, that we're going to see more and more usage of this testing in remote settings first. And we need more data about this, about what's the cost, what's the effect. I know from speaking to Abbott that the iStat machine itself is the newer generation iStat machine that you need. There's an older version that won't run these cartridges, and the cartridges are priced at about $100 right now. So you'd have to do the health economics and the math of how much you're going to be saving, both from a cost and from a patient intervention and time resource cost index. But assuming that it proceeds the way the literature currently looks, it'll have a use case in remote settings for sure. That's my feeling.
Okay. Probably our listeners are wondering, I'm assuming you have no conflicts of interest with Abbott?
That's correct. I don't have any affiliation or conflicts of interest with Abbott. That's correct, yeah.
Excellent. One thing I just wanted to pick out of this case was, yes, according to the Canadian CT head rules, more than 3 times vomiting is an indication for a CT in a patient with a head injury if they've passed all the other exclusion criteria from the tool. In pediatrics, we've talked before about isolated vomiting. So, you get a kid that hits their head and they have isolated vomiting, and in every other way, they're perfect. How do you sort those patients out who are pretty much fine in every other way and they're just vomiting? Because, in pediatrics at least, there's some pretty good data to suggest that if it's just isolated vomiting and nothing else, that they don't need a scan. And
I would 100% agree with you. In our community emerge, where we see kids who hit their heads all the time, it's such a frequent presentation. The vast majority of them don't have intracranial hemorrhage, and we would much prefer to observe some of those kids. So the similar applies to adults with less of a concern about radiation risk. The CT head involves 100 chest x-rays of radiation, and that effect for adults would be significantly less than for a child. So how do we make that decision? We base it on a few factors. We base it on, number one, what's our ability to get a scan quickly if they deteriorate? So if you are near a CT scanner and can move quickly, it allows you to observe them actually longer because you can get the scan if you need to quite rapidly, versus it's a higher stakes decision if you're in a remote setting and you have to transfer the patient still for hours and you have to arrange transport, and the nurses may or may not be capable of airway intervention if they deteriorate rapidly. So what is your pretest probability that they're going to be deteriorating? What is your sense and your gestalt that there is another alternate diagnosis that's more likely? Are they vomiting because they have gastroenteritis? Are they vomiting because of some other, they're drinking, as in this case? So those things all factor into your decision-making. What time of day is it? Those kinds of simple things do affect your decision-making. If the nurses in the nurses station have been working for 18 hours and they need to sit there to observe the patient for another 4 hours, you're not sending them home while they're vomiting. So those kinds of simple things go into your decision making as to whether you want to pull the trigger on a test or pull the trigger on a transfer, and where is the patient going to be safest. And I think, once again, like everything else, you go back to, what would I do if it was my family member? What would I want? Would I want them shipped out for 14 hours somewhere, or would I want them observed? Or would I want them to get a scan if I'm sitting beside a scanner and my child's only 5 years old? These decision rules, for example, the Canadian CT Head Decision Rule is an amazing piece of research, but it's a rigid piece of research. It's not designed to be used in situations with nuance and context, and there's no possible way to design a rule. That's why we're there.
Absolutely. I've said this many times before on EM cases, but that I have the utmost respect for physicians who work in the far north in Canada and other rural centers, because these are tough decisions.
Let's take a little break to hear from one of our sponsors, Metricaid, the experts in complex physician scheduling since 2012. Metricaid's expert schedulers are their secret sauce. These people truly understand the complexities of physician scheduling. They empower us by providing the tools we need to manage our teams efficiently. At the same time, they give physicians more freedom to share their workflow preferences, so schedules aren't just fair, they're actually workable. Metricaid's system is built to make your schedule work for you. They take the stress out of shift planning so that you can focus on what matters most. Go to metricaid.com/emcases to learn more about how smarter scheduling can work for you. That's metricaid, one word, .com/EMCASES.
Our final case, here we go. You're in an ED with access to CT but not MRI. A patient arrives with symptomology that's concerning for cauda equina syndrome. They've got severe low back pain. They've got mild bilateral leg numbness, perhaps mild weakness, which is kind of difficult to tell because they're in so much pain. There's no incontinence of stool. Rectal tone and perianal sensation are intact. And you get a PVR, and it shows 180 milliliters. So the question here is, should they be transferred for an emergency MRI? And if you can't get a transfer or you can't get an MRI for whatever reason in the next 8 hours, are there any other choices besides calling the neurosurgeon and begging to be transferred to the neurosurgeon without an MRI?
Yeah, this case, I've actually had variants of this case over time, and I suspect many people have because, as you know, cauda equina is a tough diagnosis when it's early in the course of cauda equina. It is a high-stakes diagnosis, but it is in the setting of back pain, which we see all the time in emergency. So we need to be vigilant for cauda equina. We also know that the resource cost of obtaining an MRI emergently from Emerge is quite high. If you work in a center with an MR, it's sometimes difficult to get MR. If you have to transfer out for an MR, it can be a nightmare to find a accepting venue. So there are some pieces of literature that are very relevant for us that have come out recently, and I want to highlight two of them. So number one, you mentioned PVR. So there's been some recent research in the last 5 years, including some systematic reviews and a prospective trial, and I'll give you the brief summary. So if you have a PVR of greater than 200 mils, your sensitivity in picking up cauda equina syndrome, if you have an elevated PVR over 200 mils, is over 90%. In the best prospective study that was done recently, it was 94%. What that means is if someone has urinary retention on their bladder scan, you can be very suspicious that they have cauda equina syndrome versus if they don't have urinary retention, your suspicion goes dramatically down. It doesn't mean they can't have early cauda equina syndrome before their bladder gets impaired, but their likelihood of needing operative intervention is extremely low. So you can use that as a risk stratification tool. And if you're calling any spine service, they will want to know the PVR. So you should absolutely get a post-void residual on any patient who you see with radicular symptoms just to ask about bowel and bladder symptoms. And if there's any concern that they're having any kind of urinary symptoms whatsoever, you should be getting a PVR.
Okay, that's great, because I used to give talks on low back pain and cauda equina syndrome. And when I looked at the literature at the time, there was never anything that said, first of all, exactly what the cutoff should be. And then there were never any studies that gave us really how sensitive it is. And so, it's like, well, at that point, it was like, if it's under 100 mils, we know we're fine. But then there was this is why in the case I gave you, I said 180 mils, because there was kind of a gray area in there. So that's really good to know that now we have some pretty good evidence that it's 94% sensitive.
Yes, correct.
For 200 mils. So those are the numbers we need to know.
Those are the numbers. And the other comment, and you brought up a great point, because when I was taught, I think we're all taught slightly different numbers of what is an abnormal PVR or post-void residual. So I was taught 150 mils. And when they did the systematic review, so there's a couple of recent papers out, but the prospective study found 200 mils was the best cutoff, to pick it up.
Great. Finally, we have a cutoff.
We have a cutoff. Now, if someone has 180 mils, like you described, actually, that's a great number to pick in this case. It's still actually abnormal, so 180. So what you're looking for really is you're hoping it's going to be less than 100. Less than 50 is normal. If they're older and they may have a little bit of prostatism, then less than 100. The way I would use the data that's out there is, once you start to get over 150, I'm concerned, and 200 is the cutoff that's used in the literature. So, I don't think you can use 200 as a black and white, just to be clear, but it gives you a number that is literature supported to discuss with your neurosurgery colleagues. And it, as I said, it should highlight for all of us that a post-void residual is an absolutely essential test to get. And I spoke to a couple of my spine surgery colleagues, when I was preparing this lecture, and they emphasized the post-void residual is one of their key go-to questions when they're talking to someone who's trying to transfer someone in, because they want to know that. It's very helpful to them.
Beautiful. I'm just so happy that you so eloquently described. Now I know the perfect approach for PVR.
Yeah.
Excellent. So that's the PVR part. Now let's talk about MRI that you can't get, let's say, in the next 8 hours, or it's a long transport or what have you. For whatever reason, you can't get an MRI right now. Are there any other options besides PVR? Let's say you get your 180 PVR and you're not sure. You really need imaging of some kind. What are you going to do?
So I had this exact case where I actually transferred in a patient from a community hospital into our academic center to get MR because they had severe back pain, and the story that we described, and had a larger PVR on, clearly was in urinary retention, was a young guy. So he got sent in, but our MRI broke on that day. So the goes to the spine service, the MRI is unavailable. They did a CT and took him to the OR, which raised the question for me, how useful is CT? Because of course we all know that MR is the gold standard for diagnosing cauda equina syndrome. And I will reemphasize that has not changed. MR is the gold standard. The reality that we work in is we have one of the poorest access to MR, and specifically emergency MR, in the OECD countries. I mean, we currently have a difficult time getting emergency MRIs in a timely fashion, and specifically within the short time frame that's recommended if you truly suspect cauda equina syndrome. Our spine services certainly at times are extremely overloaded, and we know from the literature that when you look at the number of transfers into spine services and the number of people that actually go in for surgery for cauda equina versus the number of people that are sent in, there's a very high negativity rate. A lot of people are sent in, and we also know that the patients can be very difficult to evaluate. Sometimes they actually can have retention just because of a pain syndrome. They stop peeing because they're in so much pain from their mechanical low back pain. So this is a complex situation. So what is the utility of CT? And once again, there's a couple of interesting papers that have come out in the radiology literature. So this is not the emergency medicine literature, but it's the American Journal of Neuroradiology, where these radiologists said, we think that CT can actually help to rule out cauda equina syndrome. And what they found is that plain lumbar CT has a sensitivity and specificity of approaching 97% for people who have true cauda equina syndrome. So it can be an excellent test to rule out true cauda equina syndrome. I'm going to put a couple of caveats in there. So the way they did the CTs in their study, they developed a specific protocol, which is not too different from the standard protocol, but they did have specific expertise in this. And they were demonstrating that there was 50% thecal effacement as their number that they use. So basically, they're looking to see, does the disc push into the thecal sac and how much does it push in? And what they found is CT can tell you if there is room in the canal or not to a sufficient degree to help risk stratify people. So it can be a useful adjunct. No neurosurgeon is going to go to the OR based on a CT alone if they can get an MR. They want the MR. The utility of the test, I think, is in very specific situations where you have no access to MR imaging, okay? Now, it would be a true shame if we, because of resource utilizations, started to use an inferior test on a routine basis or started to then CT everybody with back pain thinking, oh, I don't want to miss something, because you now have a huge amount of radiation exposure. So this is a very delicate issue in the sense that we obviously have pretty easy access to CT. We have a lot of people with back pain, and we don't want to miss cauda equina syndrome. The way I take all of this literature is, number one, you do a good history physical exam and you check the PVR, you check for bilateral limb weakness, you check for perianal sensation. Rectal tone you can check for, but the data on how good we are at picking up people with poor rectal tone, it's not a great test, to be honest, unless they're actually leaking stool and by the time they're doing that, they will always be retaining urine, to be honest. But you do a good history and physical. If you're suspicious of cauda equina and the PVR is positive or there's other super high-risk features, you call and get the MR and you call and get the transfer to the spine service. Nothing has changed. But if you're in a very specific situation where you can't get any of that done, it is useful to know that the CT lumbar spine is a useful adjunct test in very specific situations. And it's useful to have that literature in the back pocket to talk to your radiologist too.
Yeah, again, I'm feeling pretty good because it was just a couple of weeks ago I had this exact situation where the MR was only available in the morning. And I had a discussion with the radiologist and got a CT scan.
Oh, really? Interesting.
Yeah, exactly. Yeah.
So exactly that
and
scenario.
So but I didn't know about these studies. So again, currently in 2026, there's a 97, that's remarkable, a 97% sensitivity. And I'm assuming this is like the modern plain CT read by an experienced radiologist. And it's really that fecal effacement.
Correct.
That you're looking for. So I think those details are very important. It's the fecal effacement and it's a high slice plain CT read by an experienced radiologist. And that's as high as 97% sensitive. And so if you can't get access to an MRI, that is not a bad screening test, at least.
A couple of other pearls I'll mention from speaking to our neuroradiologist and our spine surgeons about this issue. So number one, the CT, who can it miss? So it's not 100% sensitive. If you have a disc herniation higher up than L4, L5, and it fills the canal, it can abnormally give you a reassuring scan. So those are probably, it's not 100% sensitive. So that can be a imaging miss if the herniation occurs at a level higher up and it completely fills the canal, and then you actually lose the ability to differentiate the signal, and it would be a more challenging pickup. And there is the old test of CT myelography, which can be done as well. And CT myelography, all it means is that we do a lumbar puncture. Essentially, you get into the canal and you inject 5 cc's of contrast. So there's a special IsoView M, which is a specific IsoView contrast, which is rated for myelography. And many departments have that. If you inject 5 cc's of that into the canal, your radiologist can do a CT myelogram. So once again, you would do that only with discussion with your radiologist. But if you have a high stakes case and you absolutely can't get testing with an MR and your plain lumbar CT is non-diagnostic or there's some concerns, that's actually another option that was mentioned. So those are all adjuncts to use specifically in MR restricted situations.
Great. So suffice to say that if you can't get access to an MR, You're going to advocate for a CT. We know that it's 97% sensitive, but of course, for such a horrible disease, those patients still need an MR if you have a very high clinical suspicion.
Is
that fair to say?
CT will not pick up early cauda equina syndrome. So as you know, cauda equina, when it first presents, we would actually ideally like to intervene in people who are developing symptoms before they lose their bowel and bladder function. So that's a different scenario.
There is an argument to be made that once you have full-blown cauda equina syndrome, that there's a good chance that the surgeons won't be able to fix them. And it's really, we want to get them, before they get to that point.
Yes, we would, there's good success rates if you intervene early in those people, but waiting until you have lost your bowel and bladder function, I don't want to be in that situation, obviously. So people who have progressive low back pain that is severe and debilitating, have seat numbness, have perianal symptomatology, complaints of bilateral leg weakness. Sometimes their complaints can be intermittent and positional. It can be a very challenging diagnosis. That's one of those gray areas in emergency medicine that's very difficult. I personally don't have access to emergency MR for those patients, but I can be suspicious. And that's a different topic. But those are the patients who you might put in a very urgent MR request because they have a good story, but their PVR is negative. I'm not going to be able to get an emergency MR on those patients. And CT lumbar spine is not going to do anything for those patients because those patients don't have thecal sac effacement. Their post-void residual is normal. So in those people, they really need an MR, but they need an urgent MR.
Okay, great. So there's definitely some nuance there.
There's a lot of nuance.
Okay. Yeah,
in
we
this
don't
kind
want
of thing.
We don't want our listeners to go back to their emergency departments thinking that CT is a replacement for MR for cauda equina syndrome.
Yeah.
Great. All right. Well, thanks so much, Amit. That was so much fun, and I learned so much, and I hope our listeners did too. I feel like every few months it would be amazing if we could just come up with some more cases for us to chat about. Dr. Shah has been speaking at EMU for, a decade at least?
Yeah, many years, yeah.
He is a fantastic speaker. So anyone who wants to hear more of Dr. Shah, the EMU conference is a great way to strengthen our community. And we'll definitely have him speaking at an EM Cases Summit at some point.
Well, thanks. I'll really look forward to that. Thanks for having me, Anton.
Before we go, I just wanted to mention that there are not one, not two, but 3 pre-conference courses that we're offering at the online EM Cases Summit this November. The online Hearts ECG course with our very own ECG master and the brains behind our very own ECG Cases blog, Dr. Jesse McLaren. The online Synapses course for neuroemergencies with EM Cases co-host Katie Lynn. And the third course we're offering the summit is run by probably the most frequent guest expert in EM Cases history, the very first guest I had on episode 1, in fact, Dr. Aaron Ciel's casted radiology course. Space is limited for these courses, so please go to emcasessummit.com now to register for the online summit conference, and you can choose one of these courses before they sell out. So until next time, take it easy.